to them, and we have our first speaker, Dr. Ridhima Bhagali, who's a consultant cataract and refractive surgery from MediLaser Pioneer Eye Hospital, Pune, who is going to be showing her first very challenging video. On to you, Dr. Ridhima.
Thank you very much, ma'am. So, very good afternoon to respected seniors and friends. Yes, Mr. Anand, I think we can play the video.
This video demonstrates various techniques of managing zonular dehiscence at the time of cataract surgery. In case of a localized, non-progressive, single-quadrant zonular dehiscence, the wound and rhexis are initiated away from the area of dehiscence. A capsular tension ring is placed in the bag after a hydrodissection to provide extra support to the bag at the time of phacoemulsification. The second case is a traumatic mature cataract with 4 clock hours of zonular dehiscence. The rhexis is lost to the periphery and is being completed with the microrhexis forceps. Now a CTR cannot be used in this case. Hence, capsular hooks are being used to stabilize the bag at the time of phacoemulsification. A 3-piece IOL is then chosen for its tensile strength and the haptic is oriented in the area of zonular dehiscence. The next case shows a 2-quadrant of 5 clock hours of subluxation. Intracameral triamcinolone is used in an attempt to identify any vitreous. The wound is made away from the area of subluxation. After the initial nick, often forceps are required to complete the rhexis. Here, a dialer is being used to provide counter-traction in the absence of zonular support. My plan here is to suture the bag to the sclera in the area of subluxation using a capsular tension segment. After making a scleral pocket in the overlying area, a double-arm tenoproline suture is threaded into the eyelet of the capsular tension segment. Both arms of the tenoproline suture are thus retrieved using the railroading technique under the scleral flap. Capsular tension segment now needs to be placed through the main wound into the bag centered in the area of zonular weakness such that both its arms are in the bag while the eyelet hooks over the rhexis. Anterior vitrectomy was needed here to clear the vitreous, interfering with proper placement of the CTS. After proper placement of the capsular tension segment with both arms in the bag and hook over the rhexis, both arms of the tenoproline suture are then pulled and tied under the scleral flap and secured. With the bag now sutured to the sclera, phacoemulsification can proceed with careful movements. Direct chop is preferred to minimize stress on the zonules. A capsular tension ring is still required here to equally redistribute the stress of the intact zonule and to center the bag. During irrigation aspiration, the aspiration movements need to be slow and tangential versus perpendicular with a CTR in place. And lastly, the IOL goes directly into the bag without any additional maneuvers to induce zonular stress.
Thank you very much. In the 4 minutes, if somebody could teach entire thing about subluxated cataracts, you have done it all. You showed everything along the way. Now, I would, yeah, very nice videos. I would ask the first question, which I'm going to be asking expert panel, and of course, Ridhima could also put in a word. Dr. Chandrasekhar, I would want to ask you, would you believe that you need to place a CTR every time when there is a iris and a lens coloboma, and when there is not an obvious subluxation seen? And would you ever think there is any validity of suturing the iris coloboma?
Good afternoon, everybody. First of all, very good demo and nice videos. Madam, if the subluxation is less than 2 hours, then I don't think CTR is necessary. But the first case you showed, the subluxation was more than 3 clock hours. In that case, it is better that we put a CTR. And yes. Because the stability, the centration of the lens will definitely matter.
Yes, there could be an asymmetric back contracture, and placing a CTR, I think, is a relevant step to go. Yes.
Correct. What is the second question?
Whether would you ever think of suturing the iris coloboma?
Iris coloboma, it depends on the patient profile, basically. It is very difficult to give simple answer, but in principle, yes, I would like to suture iris coloboma to give very good, better quality of vision to the patient.
Dr. Swapna, with the patient who's already visually adapted to that iris coloboma from childhood, would you actually feel the need to suture the iris coloboma? Your thoughts, Ramuti's thoughts?
Yeah, that's the point. Basically, the patient is adapted to that amount of light reaching the eye. And secondly, sometimes the coloboma is very U-shaped. And it's very hard to bring the ends of the coloboma together to form a proper pupil. And sometimes there's cheese wiring of the sutures as well. If you attempt to do that, maybe you can put something very near the root if you want to, have a properly formed pupil. Or sometimes you can keep an iris segment also. So in many cases of coloboma which are large, and you want to reduce the photophobia the patient may have, because even if they adapt it, sometimes they keep their eyes very closed when they are exposed to light. So to sort of relieve it to some extent, you can keep iris segments also, which will prevent too much light entering the eye. But if it's a small coloboma and the patient is used to it, no.
Madam, hello.
Yeah. Yes.
Can I add a few points here?
Yes.
Actually, the questions you asked were really fantastic concerning the zonular dialysis and zonular weakness. Coloboma being a non-progressive zonulopathy, and if the zonular defect, as Wavekar sir rightly said, if it is less than 2 clock hours, there is no need of CTR as such or capsular supporting devices, provided you put a 3-piece IOL supporting that zonular defect. That is one. And another I would like to highlight here is, though the patients are adapted to that particular light things with the coloboma in childhood, but after the surgery, that portion becomes little fibrosed and opaque, and diffraction of the light happens because of all those opacifications. So it is better, always better to try and suture coloboma defect if patient is willing to close that and is willing to pay for.
The other question
I would beg to differ here for a simple reason, like especially if you're doing, I have seen patients in whom I have not put a CTR, and I have seen them 10 years later on with the entire IOL back complex going down.
Yes.
So it's always better to have a CTR in place in even the slightest doubt that you have some kind of a zonular laxity, whether it's a posterior zonules or the anterior zonules, and it's a safeguard for your future. It's not about the present.
Yes. The other question which I have, which I would ask Ramuti to take, is in that particular case where she had a rhexis tear, I think CTR cannot be placed, but a CTS could have been placed. But again, probably because this is a non-progressive kind of a scenario, she decided to just place the haptic of the IOL itself to support that area of zonular weakness. Your thoughts, Dr. Ramurthy?
Sorry, I didn't notice a rhexis tear. I mean, where was this rhexis tear?
Ma'am, sir, the intermittent cataract, the rhexis ran away to the periphery, 180 degrees opposite to the area of the dehiscence.
Okay.
Second
The
case.
rhexis ran off.
Okay.
Yeah.
Just some thoughts. One thing is, I don't think it's necessary to suture up a congenital coloboma. First of all, it's quite challenging. The patient has lived with a clear lens and has well adapted. And even if it gets fibrosed, that's going to only block the light at the capsular area. So generally, we have not been suturing for years, and we have not heard any problems with that. And I would tend to agree that whenever you suspect zonular weakness, go ahead and put a CTR. But the timing of putting in the CTR, for example, the first case, immediately after you made the capsular rhexis in a fairly stable bag, you put the CTR. I think we all know that the difficulties once you have the CTR in place. So I'd have gone ahead and done a gentle phacoemulsification. And I'm sure with that stable bag, the entire process could have been done. And just before putting in the intraocular lens, might have placed the CTR more for dealing with any future chances of the zonular weakness progressing, and which usually doesn't happen with a coloboma. And second thing is, as far as the second case is concerned, the intraocular lens, first of all very beautifully done surgeries, kudos to you. And second case, I would feel that, it's not just positioning the haptics in the area of the zonular weakness, but nowadays the present day concept is to go ahead and place the haptics in the capsular bag and create a reverse optic capture. And if you have the optics in front of the rhexis margin, that gives you extreme stability. And we have started doing that, and it seems to work quite well. And your last case was, what was that?
That he has placed a CTS.
The CTS again, I would feel that the CTS is for prolonged support for the capsular bag in the future. And in that case, what I would have done is to go on ahead, and you again did it beautifully, used a couple of capsular hooks to support the capsular bag, completed the phacoemulsification, because during the phacoemulsification, you need the anterior support. And subsequently, once the lens matter is out, placed a IMH segment and the endocapsular ring to tether the capsular bag onto the sclera, and also give circumferential support. So maybe it's just the timing of placement where I would have slightly differed, but otherwise I think you did everything very well.
Yeah, that
Thank
was
you very much, sir.
which I was.
Valuable.
Yeah, no,
In the second case, there was something a bit off that I noticed, because your rhexis extended in the direction opposite to the point of dehiscence, and when you kept the haptic against the dehisced area, I am sure the other haptic would have been in the region of the capsular runoff, which is a dangerous situation.
Yeah.
So, like sir mentioned, I think you should have kept it at the opposite direction.
Yeah.
No, just one more thing, ma'am. I think maybe in these subluxated cataract, this is one indication where flax probably gives a very good centered rhexis, and if you can center it on the scan capsule, it works well to those people who have access. But even in pediatric cases or here, because mostly the rhexis is the most critical part in this, so we cannot, most important part. So if at all you think of flax, I think this is one indication where it really is good, especially.
Yeah, true.
This is where
And of course,
we don't want a runoff like this.
Before I go on to our next speaker, would all of you feel that a CTS should be placed in the end? We could use capsular hooks, do the surgery, and then place a CTS?
Yes,
capsular hooks, first capsular hooks, and then CTS. Yeah, of course. We need anterior support, as sir has rightly said.
Yes. Thank you very much, Riddhima.
The surgery easier also, I couldn't have maneuvered a CTS inside with the whole nucleus inside. She did it beautifully.
Yeah.
I mean, so we must appreciate that.
Yeah.
The technique of doing phacoemulsification was perfect because he was withdrawing the nucleus and then chopping. All the forces were acting towards the tip and then on the zonules.
Yes.
The zonular stress was least.
Very good.
That was a beautiful.
Yeah, hats off to you, Riddhima. If you could continue to be present on and off and watch the other things, it's a learning actually.
Yes,
Thank you very much.